My name is Kelly Atchison. I think I failed to mention that, but I speak with several of you, or have spoken to several of you, and I serve as the NFED Director of Family Support and Outreach. I've been with the NFED for about 10.5 years now, and I do want to welcome you to tonight's conference call. We have Dr. Richard Lewis, who's going to speak to us on eye concerns that are related to the ectodermal dysplasias. As I did mention, the call is being recorded. We will use these recordings as future education. Once later this week, you'll receive a link to the recording, and so you'll be able to listen to all of the question and answers that are offered tonight, and you'll be able to save that to your computer for future reference. But we'll also make that available on YouTube. And we're also in the process of creating an iTunes channel because we'd like to make these calls available by podcast. So if there's anybody on the call that knows how to do that, give me a call or send me an email at the office because it's been a very slow learning process for me. And I'm always looking for volunteers. So with that being said, our call will last for 1 hour. This is an interactive call, so it's question and answers. And that's why we have Dr. Lewis on the call. This is how he operates or runs his session that he usually does for us at the National Family Conference. If you've attended those events, you most likely have met Dr. Lewis at those events. I think you've missed maybe one conference. Is that right, Dr. Lewis?
I think so, yeah. Just one since I came on the board.
And you've been on the Scientific Advisory Council for how long?
Oh, dear. Do I really have to remember? More than a decade.
More than a decade. We'll leave it at that.
Thank you.
Well, let me introduce Dr. Lewis, and then we'll get started. So Dr. Lewis was born in Massachusetts, and he graduated from the Roxbury Latin School, Harvard College, and University of Michigan Medical School. He trained in ophthalmology at Michigan and an additional year at macular diseases at the Albert Einstein School of Medicine, New York. And is it Bascom?
Yeah, Bascom-Palmer.
Bascom-Palmer, Eye Institute, Miami, in Miami, Florida. So after 5 years on the faculty at the University of Michigan, he was recruited to Baylor College of Medicine, and he is now a tenured professor in the departments of ophthalmology, pediatrics medicine, and molecular and human genetics. So although his clinical practice covers retinal disease, including ocular complications of diabetes, hypertension, and the ocular manifestations of systemic illnesses such as AIDS, his research interest has focused on genetics and hereditary eye disease, particularly those in infants and children. His collaborations in the Department of Molecular and Human Genetics at Baylor have led successfully to the identification of more genes for hereditary eye disease than any other clinical ophthalmologist in the United States. And we are so very fortunate to have Dr. Lewis as a part of the Scientific Advisory Council and be such a wealth of knowledge for our families. And in his leisure time, he's an avid woodworker and a gardener. And Dr. Lewis is married and has 2 children. And does everyone reside in Texas?
No, our son now lives in New York City, and our daughter works for ExxonMobil, and she lives in Washington, D.C., but works in Fairfax, Virginia.
Okay. So he gets to travel a little bit, I think, and not to mention his travel to the National Family Conferences every summer to join all of us at those events. But as I mentioned, Dr. Lewis is a wealth of knowledge, and anytime we have questions, it's very easy to just send him an email, and he's always very informative. So I know that we're all going to enjoy this call tonight. I will give us sort of a countdown through the call this evening to let us know when there's about a half hour left. We want to try to get everybody's questions in. Know that it is a possibility that may not happen, but we will certainly try. If the questions can't be addressed, you can send them to me, and we'll do our best to get a response to you in a timely manner. Okay? Are there any questions before I turn things over? Okay. Dr. List, do you have any words to start us off with?
Kelly, how many folks do we have on the call at the moment?
Okay, let me pull that back.
Roughly.
We have about 20 callers.
Okay. So we'll hope for other people to join, and anywhere along the way, if I say something that anyone does not understand, please stop me, because if you don't understand it, the odds are someone else doesn't understand it, and I'll try to minimize the shop talk and the jargon in our language, which is more complicated than most medical language, because ophthalmology, even its name, is largely Greek-derived rather than Latin-derived, so even a lot of physicians don't understand the things we talk about. Secondly, just to set the tone for those of you with young families, I'm an old guy, and I'm about ready on Thursday morning to wing back to very far northeast Texas, Boston, Massachusetts, and attend my 50th high school reunion. So that'll set the tone for that one. Yeah, it's called a survivorship or something like that. I don't know. So I think I was going to begin, as some of you saw in the meeting invitation, with defining what we are. Ophthalmologists are physicians first and eye specialists second. That means that, in principle, all ophthalmologists have been through 4 years of college, 4 years of medical school, although one or two medical schools actually have longer times than that, a minimum of a year of internship in some discipline or other, or complex disciplines where we have so-called transitional internships with multiple disciplines, and then a minimum of 3 years of training specialty in ophthalmology, in diseases of the eye, in their recognition, diagnosis, and management. And then after that, some of us specialized in a specific discipline in ophthalmology. So we have people who specialize in cataract surgery, we have people who specialize in corneal disease, we have people who specialize in retinal disease, we have people who specialize in retinal surgery, and so you can add another year or two on top of that earlier training before you go out and sort of hang up a shingle and profess to know something about the eye. I got into this many, many years ago in medical school because I was fascinated by the idea that you have a little ping pong ball about an inch in diameter, and heck, I can learn everything there is to know about that. So that was 30-some years ago, and I'm still learning, and we don't know everything there is to know about the eye and vision yet, so there's a lot more to do, and I was wrong in my original presumption, but I've been delighted to be in this field. Contrasting an ophthalmologist to an optician at the other end of the scale, an optician is a professional who is engaged in making and dispensing eyeglasses and contact lenses. So sometimes opticians advise on the manufacturing and supply services of glasses and contacts, and they're trained to measure different aspects of the eye and decide on what type of glasses or what type of contact lenses may be fitted, but they are not medically trained personnel. And the third group, which sometimes gets confused, is optometry. And herein lies a major concern and confusion. Optometry is a healthcare profession, again, concerned with the eyes and related structures, as well as vision and the visual system in humans. And they are healthcare professionals, but they are not trained as physicians. The confusion has arisen, and I hope there's no one on the phone who will take this as an offense. When a person graduates from a qualified, certified College of Optometry after 4 years, they are a doctor of optometry and frequently advertise themselves as, quote, the only doctor's license for eye care, end quote, which statement is true, but somewhat misleading. I am licensed as a physician and surgeon. I am not licensed as an ophthalmologist. I happen to be a specialist in ophthalmology as a special discipline of medicine. But in principle, I could deliver babies or do brain surgery. You would not want me to do that. But in principle, there is a difference. In almost all states except Kentucky, because Kentucky has just passed a law signed by its governor to allow optometrists to do invasive scalpel surgery, which is a bit concerning to me because the training that optometrists receive in school does not really allow them to have a full spectrum of understanding that level of sophistication. But that's a political issue. We won't touch that. So the next question is, why should parents and affected individuals with the various ectodermal dysplasias be concerned about the eye and vision? Well, first of all, people with ectodermal dysplasias are human, and even in this country, at least half of people, depending on their age group and so forth, at least half of all humans require some sort of device, glasses, contact lenses, and so forth, to maximize focus of an image on the retina in the back of the eye. And then the question comes, are there other aspects of the ectodermal dysplasias that require special attention from someone who is skilled and educated to understand the complications of these disorders in the visual system? So the next question then obviously is, what is an ectodermal dysplasia? And we plural, including current and former members of what used to be the Medical Advisory Board and is now the Council, defined an ectodermal dysplasia as a group of disorders in which at least two different tissues derived from the ectoderm, I'll come back to that term in a minute, are affected. And the ectoderm is an embryologic term that comes from the term ektos in Greek, which means outside, and derma, which means skin. So it's the outside layer of the developing embryo, and various tissues derive from that outer layer in the developing embryo. The skin, the hair, the nails, the sweat glands, certain parts of the nervous system, including the retina, the pituitary gland at the base of the brain, some parts of tooth development, and parts of the ear and nose and eye that involved in sensing things in the environment. And that puts us into the retina and special tissues of the eye, including the lid structures, the cilia, which are the hairs, the lashes on the border of the eyes, and the glands in the lid, which help to support the liquid tears, which keep the outer surface of the eye moist. And the outer surface of the eye has two major components: the white part of the eye, which is called the sclera, and the cornea, which is the clear wash crystal in the center through which you see. And the cornea is also an ectodermal derivative. And there are rare forms of ectodermal dysplasias in which the corneal tissues are abnormal and are opaque. Fortunately, for most of the ectodermal dysplasias, that does not occur. Behind the cornea is the iris, which is the colored part of the eye, which has a hole in the middle of it called the pupil. And immediately behind the pupil is the lens in the eye. And the lens is also an ectodermal derivative. It starts out, the cells that form the lens start out on the outer surface of the embryo and then dimple or pucker in and separate off the surface. And there are occasional forms of ectodermal dysplasias in which the lens is not formed normally, and when it's not formed normally, it becomes opaque, and we call an opaque lens, which does not transmit light, a cataract. And then in the inside, the back two-thirds of the eye is lined by the retina, which is a nerve tissue, very thin sheet of nerve tissue, about the thickness of saran wrap, which lines the inside back two-thirds of the eye and functions like the film in a camera. And the nerves, the inner surface of that retina, sends nerves, fibers up through the optic nerve to the brain, and ultimately back through a series of way stations to the area in the back of the head where the brain interprets those electrical images and forms an image, and you, quote, see, end quote. For various reasons, sometimes the corneal curvature is too steep or too flat, or somebody's still on the phone, and sometimes the eye is too long or too short, which makes people either nearsighted or farsighted, and we need some adaptive techniques to get the image focused on the retina so people can get an image in good focus. If you're nearsighted, your eye is relatively long, and therefore you need something to bend the light backwards to get it in focus on the retina. If you're exceptionally farsighted, the eye is short, and you need something to bend the light properly to get the image in focus on the surface of the retina. But again, fortunately for most situations for the ectodermal dysplasias, retina is not involved. But the lids and lashes and the surface problems are much more common among people with ectodermal dysplasias because there is a tendency for diminished lashes, which are a protective barrier for various foreign stuff in the air and atmosphere, because the glands that make the oil and the water and the mucus that form the tear film are altered and different from normal. And so some folks with various types of ectodermal dysplasias have what we call dry eyes, not necessarily dry because the volume of tears is abnormal, but because the three different layers are not adequately balanced. The tear film on the surface of the eye is fundamentally a sandwich of three layers. This is very simplistic. Against the surface of the eye, there is a mucus layer, which is the coating factor, the spreading factor. In the middle of the sandwich is a water layer, and on the outer surface, or the world surface of the tear film, is an oil layer. And just like oil on water, that oil keeps the water from evaporating. And then you have a windshield wiper called the eyelids, which blink and spread that tear film back and forth across the surface of the eye. And as the tears are continuously made, the blinking pumps the tears across the eye from the lateral side, from the ear side, toward the nose. And in the corner of the upper and lower lids, on the nose side of the upper and lower lids, there are little tiny holes which connect to drains, which drain tears down into the nose. Everyone knows if you cry, your nose runs. That's because when you have an emotional overload of tear volume, the drains are flooded, and the excess tear formation runs down through these little tubes into the nose. In some forms of ectodermal dysplasia, those little tubes that connect the edge of the lid into the nose are altered, or indeed the middle lining of the nose and the structures that allow those tubes to form are abnormal, and we get into trouble sometimes with kids who don't have an adequate drainage system, and we have to do something about that. Simultaneously, we have other people with ectodermal dysplasias that have a deficiency either in the oil layer of the tears, the water layer of the tears, or an alteration in the consistency and formation of the mucus layer, so that the tears do not do an adequate job of coating the eye, and you get the problem of sometimes historically called dry eyes, but really it's a tear deficiency, not necessarily in volume, but in function. Now that's a very fast overview of the kinds of things that we sometimes face, but there's no unifying single event. There's no unifying single thing we look for in the ectodermal dysplasias that's universal to all of them. At this point, I'm going to stop and ask, does anybody have any questions that relate directly or indirectly to that set of concepts?
I have a question.
Fire.
In regards to the chemistry of tears, you already commented that they're inadequate as far as the lubrication goes.
Right.
But I've also been told that they're inadequate as far as antimicrobial properties.
Yes and no. That's a tough question to answer. There are chemicals, there are enzymes, and there are other things in tear film. Again, remember I said this was a simplistic approach to make it a three-layer sandwich. There are proteins in the tear film called lysozymes that help protect against bacterial overgrowth particularly. But more often the problem is in the lash border and the oil glands on the margin of the lid, so that it's not in general how am I going to say this properly in proper English before former English teacher jumps all over me for my 50th reunion. It's not so much a deficiency in tears that leads to bacterial infection on the lids and lashes. It's an alteration in the structure of the lids and lashes that lead to these. And really, recurring infections on the surface of the cornea or on the inside of the lid is not a major problem for most of the ectodermal dysplasias. Lid margin disease, yes. The oil glands at the base of each eyelash has an oil gland associated with it, just like you have on your scalp. And if there's an alteration in the chemistry and the constitution of that oil, if there's a reduction in the way the lashes form, if there's a deficiency of lashes and thereby the oil glands associated with them, many of those conditions will lead to opportunities for bacteria to grow excessively. And someone made this statement to me not too long ago without a defense. We have more bacteria on our body surface than we have brain cells, which is just fine until the bacteria get really smart and join together, and then we're in deep trouble. But so lid margin disease, chronic inflammation and irritation and bacterial overgrowth, in a sense like dandruff, along the lash borders is a common phenomenon, not universal again, but a common phenomenon among many of the ectodermal dysplasias. But infections involving the surface of the eye primarily is not an issue with ectodermal dysplasias. Anybody else?
Yes, hi. I have a question. My son is 8. He's got HED.
Yep.
And since about 4 years old, we've gone to see the eye doctor on a fairly regular basis. And initially, the eye doctor we saw at the time said he's got sufficient moisture on his eye. But the most recent visit to a different eye doctor, because insurance changed, so we had to follow insurance.
I know the problem.
Yeah. But this eye doctor said he needs eye drops, that Systane eye drops over the counter, 4 times a day, because he really doesn't have enough moisture. So I was wondering, this lack of moisture issue, can it get worse with age, or can it improve, or does it vary, or?
So that's a good question, and I'm going to back you up on 2 things. First question was, when you said the term eye doctor, were you talking about an MD or were you talking about an optometrist?
Ophthalmologist.
Okay. Second question then is, how did the physician document or define, look for this, for the want of a better term, this, quote, tear deficiency? Did he put a dye in the tear film and look at the surface of the cornea under a microscope?
Yeah, it's that orange dye.
The yellow dye, which is called fluorescein. There's another dye, which is red or pink, which is called rose bengal. Did you recall his using rose bengal as well?
No, I don't. I just remember that my son had, orange-rimmed eyes after the fact.
Yeah. So there are 2 things we look for. There are 2 different approaches to looking for tear surface function. One of them is, how well does the tear film hold together and coat the surface of the eye? The easiest way to do that is with this dye that you just described called fluorescein, 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 and it's called fluorescein because it fluoresces. When you shine a blue light at it, it glows yellow. And what we will do in an adult, and sometimes with a cooperative kid, even a 4-year-old, you put a drop of the fluorescein in the tear film, and you ask the individual to hold their eye open. So they close their eye for a few seconds, and then you ask them to open their eye and not blink. And you shine the blue light on the tear film, and you wait for that tear film to thin out and break up. If the tear film breaks up under that blue light, you see holes in the tear film. In other words, there are areas where you don't see any yellow dye. You get a black hole because there's no dye in that because the tear film is broken up. or disappeared in that area. And you time that. You'll hear them silently counting themselves, 1, 1,000, 2, 1,000, 3, 1,000, and counting seconds for what's called a tear break-up time. The time from the moment the person opens their eye until you first see those holes where the tear film breaks up because there's no dye in it. And the normal tear break-up time is at least 12 to 15 seconds, and in some people longer than that. That's one easy thing to observe as a test of tear function, not thickness, not volume, but function, because one of the functions is to keep the surface completely coated and moist. The other thing that you can do, that you can sometimes do with fluorescein, is if you have places where the epithelium, which is the outer covering on the surface of the cornea, just like the epithelium is the outer covering on the surface of your skin, if that epithelium is defective, if you have pits in it, for example, if some of the cells die, anybody here ever had an ultraviolet burn or a skier's burn because they're exposed to either a sun tanning lamp or they're out skiing or something like that, and the outer surface of the epithelium on the cornea dies, if those little cell pockets die, the fluorescein will stain in the craters where those cells are missing. And so you can look at the tear breakup time, and you can look to see if there is little stippling where the fluorescein sticks into these little craters if the cells on the surface are deficient. Rose Bengal, which is, as I said, is a red, kind of a pink red dye, stains dying cells. So if you put Rose Bengal on the surface of the eye and look at it under white light, look at the surface of the cornea and the conjunctiva, which is the layer over the white part of the eye, and that stain, you see somebody, it looks like somebody spray painted or little scattered pink dots everywhere. That cell says those cells are dying because they're not getting enough lubrication to keep them moist and survive. And so you look for both of those things under ideal conditions. So to go back to your question, then I can't answer the question directly because I don't know what your ophthalmologist saw in your son. But it's a function, to answer part of your question, does the tear function, lubrication and coating, change as people get older? The answer is yes, it does. Does it ever go back to normal once it becomes deficient? The answer is not usually. And some of this, independent of the HED, is physiologic. In other words, for example, women, older women, I hope I'm not offending anyone here, maybe I should say more mature women, I see some chuckles, particularly women who have passed through menopause, will have many of the same symptoms because part of the support system for the tear glands and the accessory glands, which make the oil and make the mucus and make the water, is hormonally dependent. And once a lady's hormone levels drop, then we commonly see women who, for example, used to be able to wear contact lenses for 14 hours a day, can't wear them as long because they don't have enough moisture, either volume or function, to keep their lenses hydrated and keep the lenses moving, whether soft or hard lenses, soft or gas variable lenses. And once that occurs, it doesn't get better. We can support it. You can add lubricants, among them one of the brand names that you mentioned, and we're not going to support any particular brand or any particular company here because I have no brand loyalty at all. Sustain happens to be a particularly good one because it's fairly close to the normal tear function. But there are dozens of other, if you walk into any pharmacy, pick one, CVS, Walgreens, and ask the pharmacist for artificial tear solutions, there'll be 20 or 30 of them on the shelf with various consistencies. Some of them sting more than others. Some of them are stickier more than others. Some of them last longer. There's a sustain, what's it called? Sustain. Oh dear.
The one used is in the purple box.
Yeah, that's the newer one, and I'm trying to think what it has a special name to it.
Yeah, I can't remember either. I'm sorry.
Yeah, I can't remember. It's but anyway, you can tell I'm not a cornea specialist because I probably know that off the top of my head. And the advantage of the Systane is that it's a fairly high viscosity. In other words, it's fairly thick, and therefore it lasts fairly long. Picking up the idea that, quote, he needs the eye drops 4 times a day, no offense, because I don't know the situation, but he made that up.
So
because you don't know whether it's every hour, every 2 hours, every 3 hours, every 5 hours, every 6 hours, every 12 hours. This stuff only lasts a certain period of time, which is why you have to renew it periodically.
Right.
So the idea is well intended, but I think the question is, I don't really know what the real situation is. And let me bring that point out for everybody who's still on this call, and that is, number one, I'm only licensed in the states of Massachusetts, Michigan, and Texas. So anything I say is by way of guideline and a hypothesis. It's not directed at any one clinical situation, and it's not formal medical advice. Otherwise, I get into trouble with state agencies that tell you you're practicing medicine over the telephone, and you can't do that since you have never seen the patient, which is true. So we'll try to keep the answers as generic as possible, even if you guys ask individual questions about your own offspring. Fair?
Yeah, that's fine. I was more curious about the evolution of this dry eye, as a whole with a person, because within 4 years' time of going to the eye doctors, apparently it's been recommended to these eye drops.
Yeah, so that's the other side of the question is quality of recognition. Was it really not there for years 1, 2, 3, and 4 and now suddenly appeared? Or does this particular person, this particular ophthalmologist, have a sensitivity that he was going to put your kid on eye drops, lubricants, period, just because you got HED? That's why I asked, and again, I'm not trying to be rude here in any way, but I'm just saying that's why the question was, on what basis did he recommend, what did he or she see that led to that recommendation? If it was, it's got a mild problem with tear breakup time, my answer to that is big deal. If the child's eyes are not red, because if your eyes are dry, one of the responses is you start blinking more frequently to try to spread the tears you have, and your eyes get mildly inflamed, quote, red, end quote. Think about what happens to you if you're in an automobile on a 2-hour drive with the air conditioning on and the fan blowing on you. After a while, you get uncomfortable. Your eyes dry out because even your normal tear function won't sustain it if you're in an air conditioning system where the humidity in the air is 12 or 15% as opposed to 50 or 60%. And then you got a fan blowing on you, and that dries you out even more. And so you get irritated and you get uncomfortable. So it may be very well intended, and it may be, don't know, it's not that it wasn't a good question, it's just that it doesn't have a clean, simple answer. In general, folks with HED do not have an overwhelming problem with tear deficiency. In general. Obviously, individual situations accepted. But
okay. No, I appreciate your explanation and your answer, and I realize it's, a little vague, and I didn't get all the specifics from the doctor, this particular doctor at that time, because I had my 2 other children, and but you gave me good food for thought for it next time.
Exactly. Yeah, exactly. And you can ask the question without being rude and say, hey, wait a minute, we were trying to do this, but he's not blinking frequently, he's not irritated, he's not rubbing his eyes aren't red. So exactly why are we doing why are we doing this, and what do you see that makes you worried or makes you want to make this recommendation? It may be right, but on the other hand, to do it just to do it, isn't it fun to put eye drops on a 4-year-old?
Well, he's 8 now, and he's doing pretty good. But even that, it took a little bit to get started. But there's really no great harm in doing it 4 times a day if it's not, as needed as much as maybe we think.
Correct.
Okay.
You're not going to do any harm. And as an aside to that, the only, quote, harm, end quote, there are very rare circumstances. All of these drops that come in a multiple dose bottle, you know, a 5 or a 10 or 15 cc bottle, all of these reusable bottles with multiple drops in them have a preservative, because what you don't want to do is contaminate, you know, as soon as you touch the air or touch the lid or touch the skin or put your thumb on the thing, there's a chance for bacteria to get inside the bottle and contaminate the stuff,
Right.
the solution. And I'll come back to that thought in a moment. So there are very rare individuals who become allergic to the preservative, but that's really rare.
Oh, good.
So the solution to that one, for anybody who's faced it, is you go to these little dropperettes, the little plastic tube dropperettes where you basically tear off the top. It's got either 1 or 2 drops inside, and then you don't have to put a preservative in with the solution. That's great. That's very portable. You can stick them in your purse, you can stick them in your pocket, and you can take them anywhere rather than a big bottle. The downside is you are now paying 10 times as much for the drop as you would in a multi-dose bottle, because you're paying for the packaging. And the packaging cost is wicked when you're putting up in little dropperettes where there's only 1 or 2 drops inside. But you do take the preservative out. You don't need that anymore. But
It is about 20 minutes till 8, so we do need to move on to the next question.
Sure, I'm sorry. Ladies? Any ladies and gentlemen? I don't know how many dads there are out here.
I have a question, please. I have a son who's 16 and has been trying for a couple of years to wear contacts, and his eyes, Dr. Lewis, are typical kind of small for, you know, the HED look.
Yeah.
And he has a little bit of dryness, but nothing severe. But then again, now I'm thinking, oh, maybe he's only been seen by an optometrist, maybe an ophthalmologist might want to look, but he just can't get those contacts in, and he tries so hard.
Well, there's two.
Do you fit with your history of knowledge of HED, of ectodermal dysplasia, people trying to wear contacts, do you find that it's more difficult for people affected?
There are 2 aspects to that. One is the incentive and the fit, okay? So let's start with the first part of it, which is the mechanical thing. I'll give you a simple example. For her 16th birthday, my charming daughter desperately wanted contacts. So good old Dad brought her in, got her into our contact lens service, checked her prescription, I checked her prescription, sent her downstairs, let her go, and she got her contact lenses. Put them in. Instructions were, wear them for 4 hours. When you get home tonight, after dinner, take them out. Okay? After a year of, I want contacts, I want contacts, I want contacts, after dinner, the contact lenses came out, and they never went in again, after which she will be fed to the octopi in Marineland if I ever get my hands on her again. So one thing is motivation. Number 2, girls are much more motivated than boys.
Yes.
Okay? Way more motivated than boys. Young girls and young boys are way more motivated than old girls and old boys. Trying to fit an old boy, and I'm talking about over 40, who's never worn contact lenses before, is asking for doom. It won't work. Now, if you got a teenager who wants to wear contact lenses are like shoes. I don't care how nice they look at Saks Fifth Avenue or Nordstrom's. If you put that shoe on and it's not comfortable, you won't wear it. So the person picking the lenses for that young man has to understand, A, that he has a good fit. If it's a good fit and he can't see with them, he won't wear them. If he can see with them, but they're uncomfortable and they don't fit, he won't wear them. The third step in that is getting them in his eye. And then we're back to, is he being fitted with a gas-permeable lens or a soft lens?
Soft.
Soft. That would be preferable in someone with HED solely because of the mild tear deficiency problems, okay? And then the science gets more complicated, and this is, now I'm definitely talking out of my league because I don't do contact lens fitting myself. There are a number of different soft contact lens plastics, and the material, the plastics from which these soft lenses are made, varies tremendously in how much water it takes to keep that lens hydrated and comfortable. And I can't give you a brand, and I can't tell you that that's where my knowledge stops, because I don't do that anymore. I haven't done it for 20 years. But the more water there is in the lens, or the more water the lens needs, the more water there has to be in the tear film, which to some degree affects how long that individual can wear the lens. The flip side, of course, is a soft lens is like holding wet Jell-O, and you've got to be able to get that thing in your eye. And there's a technique to putting them in and taking them out, washing your hands and all that stuff, as well as the problem of how large his lid fissures are, how wide open he can get his lids open, and so forth, because the lenses have a finite diameter, and the cornea itself is about normal adult, which he is as a teenager, normal adult cornea is about 11 millimeters in diameter, and the lens has to be bigger than that. So usually there's a 13 or 14 millimeter diameter lens that fits. Well, that means you got to get your lids open by 14 millimeters at least in order to get that lens inside, and preferably bigger than that. That's a process of education, which the person who does the contact lens fitting, whether it's an optometrist or an optician, needs to do. And that person, the person who selects the lenses, has to pick the right plastic and has to pick the right diameter, independent of the curvature and all that stuff, because the cereal bowl has to match the beach ball in order to fit properly. I don't think there's a simple answer to your question.
Yes, I could see, and they might have chosen with the soft lens it being more water lens sufficient, and then therefore it seems to be able to flip inside out, and then you have this small eye for this big thing to go into.
Bingo.
Yeah.
Yeah. So, I mean, the other option, or at least say another option, is to find another contact lens fitter and say, hey, look, we tried this and we tried that. What other options do you have? And it never hurts to ask for an independent assessment, traditionally called a second opinion, but it costs time and it costs money, but it doesn't hurt anything to ask for someone else to give it a go and find other options and play with them.
Yes.
I mean, you don't buy the first car you look at. You try them out.
Sure. And do you recommend that children with HED or patients with HED see an ophthalmologist? Definitely.
For a complete medical eye examination, I think the answer is yes.
Okay.
Are there good optometrists who know when to ask for help? Yes, of course. Are there bad ophthalmologists who think they can do everything and never ask for help? Yes, of course there are.
Okay. Thank you.
You're welcome.
Thank
Hi,
you.
my name is Laura.
Go ahead.
Go ahead. You can go.
No, I was just going to ask for another question. You're fine.
My name's Laura. I'm from Rhode Island. And
the plantation of Rhode Island.
Yeah. I have a 2-year-old, and he has HED. He does not, and we have never seen him cry tears. We did bring him at a year old to an ophthalmologist at Yale, and he's going once a year. He told me not to be concerned right now, so I'm not really sure what right now means. We do notice he does rub his eyes a lot. His eyes are red a lot. When he tantrums like your typical 2-year-old and without the lack of tearing, his lids and around his eyes almost look burned. Should I be concerned, or is there something I should be asking?
Yeah, because now there's the other end of the spectrum, and you hit on some of the things I touched on a minute ago. If his eyes are, first of all, if he doesn't have emotional tears, that's telling you that his tear glands are not pumping out water.
Okay.
Which then implies that if his eyes are, quote, red, end quote, or whatever term you want to use, irritated and stuff, at rest, in other words, without the emotional tearing, that says he may well have a concerning level of tear deficiency.
Okay.
Now, again, I'm talking about tear deficiency, not saying dry eyes. I'm simply saying that there's an imbalance that doesn't allow adequate lubrication of the surface.
Okay.
That's a child where it would sound like, again, not being able to examine him all that stuff, where tear supplements would be useful. Now, what other options do you have besides tear supplements? There's a second option. You start always with the easy stuff, and the easy stuff is tear supplements, artificial tear solutions. The next step above that are plugs. Remember I said there's a drain in the upper and lower lid in each eye?
Right.
Because we are upright creatures, the upper tear drain does about 20% of the work, and the lower tear drain does about 75 or 80% of the work for draining into the nose. We now have little silicone, and they look like champagne corks, little teeny plugs which go into that hole on the lower lid. The hole is called a punctum, P-U-N-C-T-U-M, punctum, which is the Latin word for point. And you plug the hole. And the nice part about the silicone plugs or silicone caps is they're completely inert. They can stay in there for years. They won't, because the kid will grow and the punctum will get bigger, the tube will get bigger, and they'll eventually fall out. But they're totally inert. And so what you do here is you salvage the tears that are made and keep them in longer, but you don't put plugs in the upper ones. You always put them in the lower ones.
Okay.
And I'll make this up. If you have a kid who then is tearing all the time and he's got tears running over the surface because you've plugged up 80% of the work, no problem. You pull the plug out and you haven't done any damage to the normal anatomy. In the past, people talked about cauterizing the punctum and closing it permanently, or taking a laser and searing it closed. I do not like non-reversible procedures.
Okay.
I like things you can do and try and reverse. Now, he would have to be either mummified, wrapped up in the office, or sedated in order to get that in a 2-year-old.
Right.
Or you could even do it, except if you're going to put him under anesthesia or under sedation, you'd probably want to do both eyes at once. But if he was a bigger kid, if that came up in a bigger kid who was cooperative enough to put him in the office, you might put him in one eye, put a plug in one lower lid, and leave the other one as a control to see whether the one that got the plug got better and the other one didn't. But if you're going to have to sedate a child to put him in, you might as well put him in both lower lids.
Right. Okay.
And the third topic that comes up, which we come up at the family conferences, is restasis. And I will express my same opinion as I have in the past. Restasis, which all you ladies know, is being very heavily advertised on television as the treatment for ladies with tear deficiency. Notice they're targeting a particular audience here for a particular reason. Restasis is a chemical called cyclosporin. Cyclosporin was discovered in Japan a number of years ago, and it's a very potent immune suppressive drug. It has been used predominantly, initially, as an anti-rejection drug for people having solid organ transplants, kidney transplants, heart transplants, and so forth. Several years ago, the company that distributes it got the idea, gee, if there's an autoimmune or immune component to dry eyes, we can use it in an eye drop to reverse, or perhaps reverse is a bad word, slow down the progression of drying in older age group individuals and certain inflammatory diseases like systemic lupus erythematosus and rheumatoid arthritis and some other things. And so it's been marketed for that. We have heard at the family conferences of physicians putting children with ectodermal dysplasias on restasis. Bluntly, ladies and gentlemen, that makes absolutely no sense whatsoever, because none of the kids with ectodermal dysplasias have dry eyes as a result of an autoimmune or immune response, and therefore an immune-blocking drug will have no benefit. And on top of that, it's wickedly expensive.
Okay.
We have about 10 minutes left. I'm sorry, I didn't mean to interrupt you, Dr. Lewis.
No, I can keep, it's like my electric grandmother. You plug her in and she keeps talking.
We have about 10 minutes left.
Other questions?
I have a question. My daughter is 5 and she has Gold syndrome, and she is legally blind and has colobomas in both eyes
And small eyes.
What is your experience with that, and as far as looking at the future for research and regrowing cells to correct her vision?
Boy, that's toughy.
Yeah.
Okay. She has Goltz. She's had molecular diagnostic DNA testing, yes?
Yes, through Baylor, actually.
Yep, that's why I asked.
Yeah.
And the second question is, both eyes are small?
Yes, keyholes, yeah.
Okay. Think about this problem. There were light-perceiving organelles in small multicellular organisms, worms and bacterial-like organisms, before they were brains. We, as human beings, have evolved a very sophisticated visual system which has taken 400 or 500 million years to evolve. And without being rude, you're now asking a question: do we have the power to reorganize and regrow tissues which started to form before day 5 after conception and form a normal eye? And I think, although in theory it is potentially possible, I think within my lifetime it isn't going to happen.
Okay.
And it's not, I think the difficulty is you have to go back and start basically all over again and reprogram embryologic tissues, which aren't there anymore, to do something and then connect, because remember the eye, even the optic nerve, inside a normal eye there are 300 million rods and cones in each eye. There are about 1.5 million nerve fibers on the inner surface of the retina that go up the optic nerve. The optic nerve is not a nerve in the sense a nerve down your arm is a nerve. It's actually part of the brain. So you've got 1.5 million nerve fibers in each optic nerve, which is, and that is less than 1.5 millimeters in diameter. So you've got 1.5 million nerve fibers in a space that's less than 1/20th of an inch in diameter. And then they have to go back and connect at multiple stations inside the brain. And I think that evolution and development is beyond us at the moment.
Okay. Because I mean, obviously they keep telling, no glasses, no contacts, because there's basically a hole there.
Yeah.
And that they're not, because it would be multi-layer regrowth of cells.
Yes.
So it would be very challenging.
Yes.
Okay. Okay, thank you.
But also, I should add, the doubling time of information in medicine and science is less than 2.5 years, which is really scary in an ophthalmology training program such as ours here at Baylor when we have a residence for 3 years. That means at the end of the 3 years, half of what we taught them is probably either wrong or obsolete. And that's really scary. But if you think about a person's lifetime, doubling time of 2.5 years, 5 years is 4 times, 10 years is 16 times, et cetera, et cetera. The expansion of medical knowledge is astounding.
Well, I figure time is on her side. She's only 5.
Yep,
so,
exactly.
Future. Okay, thank you.
You're welcome.
Doctor, I have a question. Our 5-year-old daughter has mild ectodermal dysplasia, and we have recently started giving her Nasonex to help open up her nasal passages. All was well until about 3 weeks ago. She started complaining of pain in her eyes about 10 minutes after we'd give a dose in the evening, and she would just sort of cry out in pain for about 15 minutes, and then it would subside. We stopped giving her the Nasonex, and then no more pain. So have you seen that connection? And have you, did you have...
is the pain in both eyes or just one?
Yes, both, typically.
Okay. Whether you spray in one side or both sides?
That's right. Occasionally she has said it's only on one side, okay? But
no, but what I'm saying, whether you put the Nasonex on one side of her nose versus the other?
We use both nostrils and always to the side.
Yeah, but so my next question was, suppose you only put the Nasonex in one side.
Oh.
Would you complain about the eye on that side or on both sides?
We've never tried that.
Interesting experiment.
Okay.
That's one step. Second step, the sensation, just like the sensation of the face, there are nerves that give sensation to the inside lining of the nose, of course, roof of your mouth, your teeth, the sinus that's above your upper jaw and behind your cheek, and there's a small sinus in your brow just off the midline. The lining of the nose, the lining of the sinuses are all the sensation there is controlled by the same nerve, which has three major distributions. On the skin surface, there's one band that gives sensation to the lower jaw. There's another that gives sensation at the middle part of the face up to the hairline sometimes in most people. And there's a third division which goes up into the scalp. If you have pain in the nose, the localization of that pain, the ability to say it's coming from X, is not the same as putting a pinprick on your skin. If I put a pinprick on the back of your hand with your eyes closed, you can tell me exactly where that pinprick is. But if you do the same thing in the nose, you can't necessarily, quote, feel it, end quote. You won't necessarily localize it. Your brain won't say, that's the sinus by my cheek. It can be referred or interpreted as pain in and around and behind the eye.
Okay.
So it's not that I doubt what she's saying. I'm simply saying it's hard to judge what's going on here. But one way to sort this out is, if she's willing to allow you to do it again, is to use the Nasonex on one side only and find out whether she says it's that eye on that side or whether it's both eyes.
Okay. I mean,
the prediction should be it's going to be that side.
Yes.
The same side.
But that would still indicate, hey, no more Nasonex.
Yeah, I mean, if she's getting repeated discomfort within 20 minutes after you put the stuff in, yeah.
Okay.
I mean, yeah. I guess I'll leave it at that. Yes.
Okay. All right. Thank you.
You're welcome.
Well, it is 8 o'clock. Dr. Lewis, it's always wonderful to listen to you and listen to your responses and have you educate us. So I do thank you all very much. I thank you for your patience trying to get your questions in. As always, there's lots of questions about the ectodermal dysplasias, and there's lots of room for more knowledge and more research. So we appreciate all the members of the Scientific Advisory Council, and especially Dr. Lewis. We thank you for your time tonight.
Thank you all. Thank you all for your patience and your questions. This doesn't work without you guys.
Thank you, Dr. Lewis.
And
Yes, thank you, Kelly and Dr. Lewis.
My email address is Kelly, and it's KELLEY @nsed.org. .org. Thank you, everyone.
And happy Mother's Day.
Thank you.
Thank you.
Thank you.
Enjoy your trip.
Yeah,
Thank you.
happy reunion.
Thanks.
All right, thanks. Good night.
Good night.
Good night.
Bye.
Thank you. Please stand by.